This is our presentation, Women with Disabilities, Vocational Rehabilitation, and Leadership Training for Advocacy.
Well, welcome everyone. I'm really happy to be here today, and thanks to everyone who made this happen. I'm going to be presenting on vocational rehabilitation, which it means empowering women with disabilities in employment. And note, please, that this is an informational presentation. Although I'm a vocational provider, I will not be providing case study examples. Instead, I want to focus on the terrific work being done on the international level. So I'm going to be talking about systems and processes in my presentation. On the screen, hopefully, you see three different images of the three different organizations that are represented. An overview of the presentation is the following. I'm going to be covering the international data on disability in women with disabilities, the definition of disability, definitions of rehabilitation and vocational rehabilitation, United Nations conventions and rules related to disability, questions and references. And I have 6 slides of references at the back in case you want to dig more into some of the data I present today. Okay, so what do we know about people with disabilities worldwide? Of the 8 billion people in the world, more than 1.8 billion have a disability. And if you calculate that out, that's approximately 19% of the global population. And the United Nations this year noted that 80% of people with disabilities live in developing countries. Let me provide the context of approximately 80% of individuals with disabilities are of working age, which means 18 to 64. Of those working age people, approximately 33% of people with disabilities, compared to 66% of people without disabilities, are employed. A little bit more about unemployment of women with disabilities. Again, if we stratify the data, but now for only women, we find something very interesting. It's different than you expect. Women with disabilities are less likely to be unemployed than other women. And this can be explained 2 different ways. Due to scarcer resources in developing countries or economies, people with disabilities may take up any available job for economic survival. That's one explanation. A second explanation is the lower unemployment rate in developing countries among people with disabilities, women with disabilities, could be due to the absence of unemployment insurance systems or social safety nets. And let's think about why we have a reduced participation in work when you have a disability. There might be a whole range of explanations. Factors may include architecture barriers, inaccessible places of employment, inaccessible transportation systems, segregated education, and a whole range of stereotypes. And these stereotypes typically focus on a person's limitations and also viewing them as a passive recipient of welfare instead of people with a wide range of interests, skills, abilities, goals, and dreams. For years, they've proposed that there is a bidirectional link between poverty and disability. So if you think about it, disability can cause poverty. So the symptoms of disability, fatigue, pain, health issues, as well as lack of appropriate and accessible employment can lead to poverty, not earning money. But poverty, not having money, can cause disability due to poor nutrition, lack of adequate health care, lack of medications. So that was a correlational model, but I think modern thought is even expanding that it's a multi-level factorial model to explain the situation. So if you start including structural factors, which can include the stigma and discrimination I mentioned, also the laws and policies of countries. We also have social determinants of health, including poverty, being excluded from education and employment, poor living conditions, lack of social support mechanisms. You have health risk factors, health system barriers. All of that can cause a range of problems that lead to lack of employment for people with disabilities. So I want to stop for a moment and consider what actually is a disability. I gave you data on it, but it's very important to think about what we are measuring. So there's many models of disability, from the medical model, social model, biosocial model, and human rights model. And the latter, the human rights model, is the most prevalent nowadays. And if any of you are curious, you look in the references for the Langtree article that lists 20 different disability models. And there are 2 internationally accepted definitions of disabilities, and I'll go over that in the next 2 slides. The first is the Convention on the Rights of Persons with Disabilities. This is abbreviated CRPD. It's an international treaty that was adopted in 2006 and went into force in 2008. And its bottom line purpose was to protect a whole range of rights of individuals with disabilities and to state the obligations of states, and states meaning countries of the world, to promote, protect, and ensure those rights. And a little bit more of about the CRPD, and let's focus on how they define disability. And I've added some italics here to emphasize some points because in the next few slides, you'll see a similar theme here. So the CRPD defined disability as an evolving concept that results from an interaction between person with impairment and their environment, and that affects or hinders their full and effective participation in society. And the CRPD also mentioned women with disabilities and noted that women and girls with disabilities are subject to multiple discrimination, and some people say double discrimination. And then the World Health Organization created the International Classification of Functioning Disability and Health, and that's abbreviated ICF. What we can learn from this document is disability should be viewed as a multidimensional concept. And the World Health Organization proposed 3 areas of functioning. So, first, you have the impairments in the body functions, structures, systems, and parts. So maybe an arm is missing, your pancreas does not work, something in the eye is not working. So that's impairments in the body functions. And by the way, this can include the cognitive, psychological, emotional functioning of people. And then secondly, we have activity limitations of a person, and this reflects impairment in areas of a person's functioning. And the third part of it is participation restrictions of the person in a social context. And the next slide provides a model of what that looks like. And one thing we can get from this, can get the sense of the person interacting with the environment, which is very important in the rehabilitation model, which you will see in a moment. And this holistic model really came out of the World Health Organization's definition of 1948. It's widely cited that health is a state of complete physical, mental, and social well-being, not merely the absence of disease and infirmity. So again, this is a holistic approach of human functioning. And now to define rehabilitation. Basically, it's a restoration of abilities to the extent that is possible given one's health conditions or limitations. And rehabilitation in the context of work is how can we use those remaining abilities to do productive work? So if you think about it, if someone loses a limb, it's amputated, or maybe they were born without a limb. Let's take the situation of the limb was amputated and they used to have a job delivering mail or packages. And so rehabilitation can help build their physical strength up, but also help them find a sedentary job, such as answering the phone in the same company in which they worked with for delivering the packages or mail. Okay, a little bit more about rehabilitation. Another definition is a set of intervention designed to optimize functioning and reduce disability in interaction with your environment. Again, those are my italics to highlight that person interacting or intersecting with their environment. And again, another key word is strengthening independence, and we do that by many different techniques, including modifying the environment, using assistive technology products, educating a person, and adapting tasks. And the United Nations definitions of rehabilitation included a process aimed at enabling persons with disabilities to reach and maintain their optimal functional levels and to reach a higher level of independence. Again, those keywords. And this is from an earlier document, 1993, and you'll find that the standard rules on the equalization of opportunities for persons with disabilities was a precursor to the Convention on the Rights of Persons with Disabilities. And just a few notes about the rehabilitation philosophy, just to summarize, it's holistic and taking into account both the person and the environment. It's pretty much a time-limited intervention, very goal-oriented, and facilitate more independent functioning. It's individualized. It's based on a person's goals and preferences, and of course, their limitations, and it's multidisciplinary. So if you think about it, there's many different kinds of rehabilitation professionals, including physical and occupational therapists, speech and language therapists, psychologists, physical and medicine rehabilitation doctors, rehabilitation counselors, community health workers. And one final note about rehabilitation philosophy, it's separate than medical interventions, and that can be explained by tripartite model of intervention that Livna described, where the primary intervention is prevention. You're preventing health conditions and diseases and disabilities. A secondary intervention is the acute and medical interventions, helping a person with a heart attack or the surgery required. And then the tertiary intervention is rehabilitation, and it has three main components. We want to minimize the residual impact of the disability, help with the skill development and acquiring skills, and also help modifying a person's environment. And brief note that the United Nations has a history of rehabilitation. They had a Relief and Rehabilitation Administration from 1943 to 48. That was to help areas of the world that were destroyed during World War II. And note that the United Nations was actually formalized in 1945. So they already were providing relief and rehabilitation during that time. If you read the documents from that administration, you'll find that no definition of rehabilitation is offered, but rehabilitation is provided both on an individual and systems level. And why that is important is I want to point out that there's many different types of rehabilitation. There's community level rehabilitation, which is an intervention with the rebuilding of the community as its focus, versus community-based rehabilitation is where you utilize community resources to help restore the individual as its focus. And a more current example of community level rehabilitation is the United Nations High Commission for Refugees, which uses a 4R framework, and that is repatriation, reintegration, rehabilitation, and reconstruction. Okay, back to the CRPD from 2006, implemented in 2008. They do talk about employment in sense of the right of persons with disabilities to work on an equal basis with others. And there's many points related to that. And here's just a few: prohibiting all forms of employment discrimination, advocating for more accommodating work environments, and requiring states, meaning countries, to promote access to vocational training for people with disabilities. And note that every year there's dialoguing about the CRPD, and that's in the Conference of State Parties to the CRPD. Okay, now what is the philosophy of vocational rehabilitation? It's an individualized process for helping individuals with disabilities enter or re-enter the workplace. And this can include a wide range of tasks, including intake assessments, creating an individual plan of employment, providing training or education, resume preparation, practicing job interviews, helping a person search for job openings, identifying accommodations to help with workplace barriers. And this is the actual type of work I do day to day. And what has the International Labor Organization said about vocational rehabilitation? Actually, they had a convention in 1983, and just briefly, with the purpose is to enable a person to secure, retain, and advance in suitable employment, and thereby to further such a person's integration or reintegration into society. And they also gave advice to states about creating national policies on vocational rehabilitation and employment for people with disabilities. Another document to take note of is the World Report on Disability. That was a collaboration between the World Health Organization and the World Bank. Chapter 8 is the chapter on work and employment. This World Report is 350 pages long, so it's chock full of all sorts of interesting ideas about helping people with disabilities, and rehabilitation is discussed throughout that document. And it provides 9 recommendations to states to implement numerous policies in order to increase labor market access for individuals with disabilities. And we should discuss the United Nations Sustainable Development Goals. These were created in 2015 as a recognition of the interconnected global issues. And there are 6 of the 17 sustainable development goals that are relevant to disability issues. And those 6 are no poverty, good health and well-being, quality education, gender equality, decent work, and reduce inequalities. And from this, you can extract the idea that disability is a cross-cutting issue. And you can see from the next slide that in fact, the United Nations has formally recognized the cross-cutting issue of disability in the sense they have created a disability inclusion strategy that was launched in 2019, and they say it's the first system-wide mechanism for disability inclusion within the United Nations. And here on the screen, you can see that an example of this is the World Health Organization's policy on disability inclusion from 2021, and you can just see how they're mapping it out. So that's good stuff. Let's circle back to women with disabilities and why work can help empower women with disabilities. First of all, there's money. Most of us have to pay our bills, and how do you do that? Typically is with work. So work can provide money. It can also provide independence, economic or otherwise. It can help increase a person's self-esteem. It can provide greater social participation, and it can help with empowerment and freedom of choice. And remember the challenges that I mentioned earlier in the presentation. Those are two pieces of data. Having a disability reduces labor market participation by 29% for women. And the other piece of data was the unemployment rate for people with disabilities, men and women with disabilities, is at least twice than those without a disability. So those are the challenges. So how can we facilitate employment? Well, we can start with providing inclusive education for all people with disabilities. We can also promote the use of assistive technology. And please note that can include both low technology and high technology equipment. And it's equipment and systems that facilitate a whole range of things for individuals. And if you think about assistive technology, it can include closed captioning, which is speech to text transcription, as well as text the other ways, text to speech reading, such as people with visual impairments or blindness. And there's a whole mobility aids like walkers, canes, wheelchairs, prosthetic devices, and hearing aids. Those are all assistive technology. And we also can promote accommodations in the workplace to help facilitate employment for women with disabilities. And how else can we facilitate employment? Well, of course, as you may guess, there's vocational rehabilitation as a facilitator of employment. And we do this by amplifying individuals' abilities. Employers hire people to do things and accomplish things. So we need to amplify a person's abilities to help them sustain a job. And of course, vocational rehabilitation and all these other supports requires states and countries to provide funds. And we know that all systems have limited resources. So vocational rehabilitation and other systems have to justify their services as worthy of investment. And we can do that from an ethical as well as a financial approach. Okay, and what do we know about the rehabilitation demand worldwide? Well, there are a lot of unmet needs for rehabilitation. And here's two quotes. Globally, about 2.4 billion people are currently living with a health condition that may benefit from rehabilitation. And in some low and middle income countries, more than 50% of people do not receive the rehabilitation services they require. And that's from this year from the World Health Organization. That's pretty stunning. And we also know about the timing of rehabilitation. And one organization noted that the single biggest problem in disability policy is that intervention is coming too late. And when it's coming too late, there's a lot of missed opportunities to ensure equal treatment, skill development, and labor market transitions. And we've known for a very long time that the earlier the rehabilitation intervention is provided, the better the outcomes. Some of my conclusions. First of all, the UN has been doing a fantastic job on focusing on disability as a cross-cutting issue and making the United Nations more inclusive. The UN has also been providing rules on decent employment as a human right. And this activity should have a trickle-down effect on the employment rates of women with disabilities. One other set of conclusions, vocational rehabilitation can help facilitate women with disabilities to enter or re-enter the workforce. It can also help empower women with disabilities, not just economically, but help them with their sense of agency, capabilities, and impact. Okay, so I'm at the end of my presentation and I can take some questions that have been submitted through the chat function. Sophia, do you want to read out the questions?
So far we haven't had any questions asked in the chat. We can also save questions for the end of the meeting, and there'll also be another opportunity to ask them.
Okay, thank you. And I didn't scroll through, but there's 6 slides with references at the end of my presentation. So thank you,
Amazing.
everyone.
Thank you, Erin. We really appreciate that. That was really insightful. Thank you. Susan, I think it's your turn.
Yeah, okay, I'm going to share my screen, my presentation. All right, so my name is Susan Dunn. I am the Senior Program Manager at Mobility International USA. Our acronym is MIUSA. And I'm presenting today on our work on empowerment and leadership training for women with disabilities. And I'm very passionate about this topic. I've been working for over 19 years on this and very excited to present to all of you here. And I really thank you for joining us. There are people from so many different countries around the world. It's very exciting. I hope to make connections with everyone here today as well. Maybe you're also working on some of these same issues and we can compare notes. Or maybe you're interested in learning more about including women with disabilities in the work that you're doing. And so I just look forward to having this be the start of a conversation, and hopefully we'll be able to stay in touch and keep that going and maybe find ways to collaborate. So the title of this presentation also I have on the screen is Loud, Proud, and Passionate. And that is the motto for our Women's Leadership Program, which really encompasses the feeling that we want women with disabilities to have for themselves, just to have a bold, rights-bearing attitude, and to see that being disabled and being a woman are both positive parts of your identity. So I'm also curious if anyone's heard of MIUSA before. So if you could put in the chat, yes or no, if you're familiar with MIUSA or our work. But I'll also tell you about MIUSA as you're doing that. So we're a disability-led nonprofit organization. We're based in the Pacific Northwest in Eugene, Oregon. Our tagline is advancing disability rights and leadership globally. And how do we do that? We're working in international exchange and international development. So in international exchange, we have had programs with over 2,300 alumni from over 139 countries. So men and women with and without disabilities, youth as well, who have participated in our exchange programs. Also really appreciate Servus for inviting us to present on this. And I know we share a lot of the same goals for cross-cultural connections with Servus. So in that work that we do in exchange. MIUSA also provides consulting on disability inclusion to international organizations, human rights organizations, women's organizations, international development organizations. So that's the other part of the work we do, mostly in international development. And I have on the screen, our logo is the MIUSA name and a globe with a little blue swoosh around it for the visual. Now, Erin provided a lot of statistics and data about what we know about the global situation, but I wanted to share a few more things just to sort of highlight why we focus on empowerment of women with disabilities specifically in our work. So the issues that impact women also impact women with disabilities, but they're often disproportionately affected. So in education, we see that women with disabilities are 3 times more likely to be illiterate compared to men without disabilities. And in some parts of the world, the literacy rate is as low as 1%, which is quite, shocking. But some of the reasons why we see this, which are similar to what Erin has already mentioned, but there's physical barriers, schools are not accessible. There's also attitudinal barriers, parents and school administrators, teachers that prevent women with disabilities and girls from going to school. When it comes to violence, women with disabilities are at least 2 to 3 times more likely than other women to experience violence. And this is like many women due to domestic violence from family or intimate partners. But women with disabilities also experience a lot of abuse from caregivers, and also those who are in institutional facilities are at risk for higher rates of violence. And then the perpetrators are rarely brought to justice. So why some of the reasons for this? Women with disabilities are seen as easy targets. If you're not able to communicate your distress in the situation, particularly women with intellectual disabilities or women who are deaf, where there's communication barriers, that can make someone an easy target for abuse. And then another area, priority area for women with disabilities is health. So compared to men without disabilities, women with disabilities are 3 times more likely to have unmet needs for healthcare. They're also at higher risk for contracting HIV and AIDS. Again, some of the reasons are, due to lack of accessibility. Healthcare providers often don't know how to accommodate or include women with disabilities. There's a lack of information. So the reasons for the healthcare, lack of information, lack of accessibility. And I just wanted to present these statistics to give you more of a context about why we do our WILD program, which I'm about to tell you about, the way we do our WILD program, and why these are such important issues for women with disabilities. So I also included the link to the UN Women Facts and Figures site where I got this information. All right, so it was so about our WILD program, which is called the Women's Institute on Leadership and Disability. And that was initiated in 1997 as an outcome of the UN Beijing Women's Conference. Now, I'm curious if anybody here remembers the UN Beijing Women's Conference. If you could put in the chat yes or no. Maybe you were at the Beijing Women's Conference. It was 30 years ago. But at that conference, that was where MIUSA actually organized a group of 250 women with disabilities to come together from all different countries at that conference to share. And what they found was they really wanted to continue to have a space to share ideas and strategies. So that's why WILD was born. And we started the first WILD program in 1997 after that. So each WILD program brings about 25 participants, all from different countries, together for an intensive training in Eugene for 3 weeks. And then we've had to date 10 WILD programs. We don't do the program every year, but to date we've had 250 WILD alumni that have gone through the program, representing 89 countries. And they this year we're actually doing the 11th WILD program. So we are going to be bringing a group this summer. We've already selected the participants for the program, so you can't apply for it for this program this year, but there is an opportunity to come and meet the WILD women. We do have an invitation-only retreat. That's a 3-day retreat that happens within the WILD program, where we invite members from human rights, women's rights, international development organizations to come and dialogue directly with women with disabilities. So if you're interested in that, you can reach out to me and I can get you an invitation. So that is open registration currently. Oh, sorry, let me just go over the pictures on the screen. So we have the top picture is just a group of 3 of our WILD women laughing and wearing their bright pink WILD, loud, proud, and passionate t-shirts. And then the bottom is a large group that is from that retreat that I just mentioned. They're outside in a beautiful outdoor green forest setting in Oregon. So now I want to share a bit about our training method. And yeah, notes are gone. So it's okay. I can do this probably. I've done this many times. And so our different areas that we focus on in WILD. 1, enhancing knowledge. So a lot of information has historically not been provided to women with disabilities. And so we are having workshops on reproductive health, on gender-based violence, on inclusive education, policy, legislation, to get that information to women with disabilities. We also have skill building work where women get a chance to practice their public speaking skills or learn about how to make an effective action plan. Another big part of WILD is experiential learning, and this is what we call empowerment activities. And this is really where you're able to challenge preconceived notions about what you thought was possible, what society thinks is possible, but also what women with disabilities might think is possible for themselves. So in those empowerment activities, you'll see we do things like river rafting. We have a ropes challenge course. But they're living with host families. So they're getting that cross-cultural experience and adapting to another culture. And then finally, fostering networks of support. So not only the group of women with disabilities, building connections with each other, but also that retreat that I mentioned where we bring in the international development professionals, building networks of support with those professionals as well. And then to describe the photos I have, the top one is a delegate practicing a media interview. We have on the bottom left, there is a blind delegate communicating with a deaf delegate, and they're kind of using a tactile sign language using their hands to communicate with each other. There's a lot of cross-disability, cross-cultural communication in WILD that is really exciting to watch. And then there's a photo of river rafting. Everybody's smiling on the river in bright yellow rafts. So the WILD training method is also has been evolving. So around 2012, we started moving toward a train the trainer approach. And we created a WILD facilitators manual that is based on the principles of what makes WILD WILD, but also allows the women to take the WILD experience to the grassroots level. And we also provide them with a small grant to do so they can put into practice immediately what they've learned at WILD. And so we're scaling up the impact of the WILD program through this. And yeah. And then also just to touch on what they really adapt it to their local context and their priority issues. So the WILD program can focus on any number of issues, and I have several listed on the screen. Oh, sorry, I didn't describe these last photos. I just wanted to say there's back on the last slide, there's a group, a world map, and it just has an arrow going from Eugene to actually Ghana, and the two photos are just showing a group training in Eugene, and then in the photo in Ghana is a WILD alumni leading a workshop outside under a tree. So that's that. Okay, now back to the issues that they're working on. So justice, rights, policy, gender, health, and a lot of the other issues we've already talked about. They're all focusing on that in different countries. I have two photos. One is a self-defense workshop in Poland. And then there is another photo of actually our next presenter, Lizzie, who's our WILD alumni from Kenya. She will be sharing more about this, but this is a photo of a workshop she did, which combined sexual and reproductive health with a wheelchair rugby workshop, which was a lot of fun. So then this next slide just shows a map of the WILD Alumni Network, where we have all the 89 countries represented by purple dots. Yeah, we're really proud of this global network that we've built of WILD alumni, and we're really proud of their accomplishments too. They've been, our WILD women tell us, they keep in touch with us for after the program and tell us about all their work they're doing. They're starting their own organizations, they're CEOs, they're starting their own businesses, they're changing policy and legislation. They're running for political office. We even have a senator in Jordan now. So really proud of the work that they're doing. And it also creates a space for sort of ongoing support for our network. And they are, it's like a global sisterhood. So we're also proud to offer this network as a resource to others who are working in any of these countries and want to be connected with disabled women leaders there to work with. So please reach out to MIUSA for that. We also get asked about how do we measure the impact of WILD and some of the sustainable ways outcomes we've measured. As I mentioned, WILD, we've only had 250 alumni from our program, but then they go back to their countries. So for each WILD program, an additional 500 on average women with disabilities are getting leadership training in their countries. So that's resulted in thousands of women with disabilities at the grassroots level. And that's created networks of support within those countries as well. We also tracked that 72% have received new funding or in-kind support drawing on resources acquired through WILD. And that is because when they go home, we ask them to make new partnerships with organizations. And so they get a lot of community supporters to fund part of their workshop or donate, something. And then after that, they go on to continue partnering with those organizations. And they're also building their capacity and reputation as respected leaders in their community through those opportunities. So, and then finally, the folks that come to meet the WILD women, they're also making changes in their organizations. So 92% of international development staff said they made changes to their programs or policies or organizations after they participated in WILD. So let's see what else. I also wanted to share a few links to we have short video documentaries about the WILD program. And then the last one is a really fun music video. If anyone wants an uplifting, upbeat break today, I invite you to watch the music video, which is our loud, proud, and passionate motto of all the women singing in multiple languages and sign language. Yeah, so I think that I hope I didn't forget anything, but I'm open for questions now, or they can wait till the end too. Thank you.
Does anyone have any questions that they would like to ask Suze?
And I can put those links in the chat. Thanks, Paige, for suggesting that.
We do still have the opportunity for questions at the end. And Lizzie, I think if you want to share your screen and start your presentation, that would be great. Thank you, Susan, for sharing about WILD. That's super informative and sounds like a great thing you're doing. Thank you.
Thank you, Susan. Thank you, Sophia. Hi, everybody. My name is Lizzie Kiama, and I'm calling in from Senegal, but my work is primarily based out of Kenya. I'm going to share my presentation now. Okay, as I said, my name is Lizzie Kiama, and I am the founder and managing trustee at Disability Trust, where we work with women with disabilities in Kenya, focusing on their sexual reproductive health rights. I took part in the Women's Institute on Leadership and Disability, the WILD program, in 2013. And my hope for today is that I can show you my 12-year journey after the WILD program, and that I can join Susan and Erin in making a case for more investments on disabled women, particularly those in developing countries, because then we can truly measure the impact of this program through the work that they continue to do. So thank you very much for the opportunity, and thank you for your attention this evening. So who was I in 2012. This is important because I think starting from where I came from and seeing what I've been able to accomplish is important in terms of measuring the impact of the program. So in 2012, 2013, I was a young mother. I had dreams for the disability sector, but I was only volunteering at an organization. I knew I wanted to do disability differently. I knew I wanted to get involved in advocacy. I have always been interested in creativity. So I knew what I wanted to do, but I didn't know how I was going to do it. My background, previously I had worked with commercial banks. So my background was more or less in the private sector, and coming from a business background, I knew I did not want to follow the traditional nonprofit or NGO model. So as I said, I started volunteering at a government agency responsible for disability, just to understand what type of work or what type of investments were going into the disability sector. I then found, through a lot of research and wanting to learn more, I found out that MIUSA existed and that there was a program dedicated to women with disabilities. So I applied for into this program in 2012. Actually, I have fast forwarded this slide, but yeah, forgive me. I applied in 2012. Unfortunately, I did not get a visa. We all know the process of, traveling to the US is sometimes, rife with challenges. So I was not granted a visa. In 2013, and this is important because USAID partnered with Mobility International USA, and the USAID office in Kenya was able to facilitate my visa application. And I was then granted a visa, and I was able to participate in or travel to the US to participate in the WILD program. Had USAID not intervened, I am not sure I would have been granted a visa the second time around. And we would not be having this conversation then. So anyway, this was my first time in the US, excited to visit the US, excited to be in a space with other disabled women, and build relationships with them. Sue's described a sisterhood, and it really continues to be a sisterhood. We are still in touch. My cohort has a WhatsApp group to date where we still communicate with one another. What stood out for me during the WILD program, my personal favorites, was the adaptive sport. Since becoming disabled, I had not participated in sports, and it was something that I missed tremendously. And so when that segment of the WILD program was presented to me, I think I immersed myself in all the physical activities, and I took up one of the activities as an opportunity for myself. It was actually very selfish because I wanted to continue to play wheelchair rugby when I went back to Kenya. So I enjoyed wheelchair rugby. I enjoyed this adaptive cycling, the swimming, the river rafting, things that I had not had an opportunity to engage with because my country had not at the time thought about what adaptive sports meant or what alternatives looked like for persons with disabilities. Okay, so after the WILD program, I got back to Kenya. The WILD program ended end of August. I got back to Kenya, and by November 2013, I was organizing my first wheelchair rugby workshop for women with disabilities. As I said before, I had worked with private sector, so I went back to my contacts and requested, their support to ensure that this event was a success. So I got my friends that were working in different companies to bring in-kind donations that were used to support the program. I also then registered a company, Disability Consulting, whose goal was to work with the private sector, because that was my background. I wanted to support private sector companies to understand disability inclusion a little better and offer more employment opportunities for women with disabilities. This is important because you will see how my work has evolved over the years. So this is where I started from. This was my intention, but I was open to the process, and the process took me to different places. I have been involved over the years in different spaces. I have supported different policy and advocacy spaces, highlighting the experience. My main goal in all these spaces is to highlight the experience of women and girls with disabilities, to improve their participation, to ensure their meaningful engagement, to increase opportunities for learning for the different actors. And I have been extremely privileged to infiltrate a lot of these spaces. For example, during the recently concluded Women Deliver Conference on Sexual Reproductive Rights in Kigali, Rwanda, I was supporting and coordinating accessibility for delegates with disabilities. And it was interesting to see that majority of non-disabled delegates also appreciated the care and attention that went into making sure the process was seamless for everybody. I also supported or coordinated a shadow report on the rights of women with disabilities to the CEDAW committee in 2017, highlighting the situation of women with disabilities in Kenya. This was important because the state report from Kenya did not contain any language, any reference to women and girls with disabilities. So I coordinated with organizations of women with disabilities in Kenya to prepare an alternative report to this process. And the result of this is the CEDAW committee was then able to make specific recommendations to the state on the rights of women with disabilities. And that then had a ripple effect amongst all government agencies. I have also been involved in CSW spotlighting at the Spotlight event in 2018, highlighting the experiences of women with disabilities, and also at the very first Global Disability Summit, where I was part of a group that held closed door events with private sector actors that resulted in increased investments for employment for persons with disabilities. Regionally, I have also supported the Beijing +25 Africa CSO review process. During the ICPD, I coordinated a side event for African women with disabilities. I have supported the Gambia with their national disability policy, UN Women, East and Southern Africa office, with conducting a mapping on gender related discrimination, among other processes that I continue to engage in. And nationally, some of the policies and spaces that I have worked to influence include the reproductive health policy, the menstrual hygiene, family planning, and such policies. Now, on a national level, and this is linked to the work that I do with my organization, the recommendations that we make to the Ministry of Health that we think are extremely important in ensuring that women with disabilities are able to access better quality sexual reproductive health is one, to integrate gender, disability, and technology into community health models. We're asking the Ministry of Health, in simple words, to employ women with disabilities as community health workers, to integrate technology, and to ensure the 5 principles of decent care work, for example, are adopted across community health models. The 5 R's include recognizing. So for us, it means recognizing the role of women with disabilities who are leaders in their community. It means reducing. For us, it means reducing the workload for women with disabilities. When we integrate technology, and we all can attest to the onset of the COVID-19, when we were all working from home and were able to utilize technology. Technology is a game changer for the disabled community. And we think that by integrating low bandwidth technology into community health models, it would be a game changer for women with disabilities to work in that space and would support reducing of the work. For example, they don't have to go door to door. People can call in. If they're utilizing a toll-free number, for example, people can call in. If they're utilizing apps or text, people can text in. So it reduces the workload and the burden on a woman with a disability. The other R talks about redistributing. And for us, it means working with partners. So for us, our work ensures that we build relationships with partners and that we are not necessarily mandated to find the entire solution to a particular issue, but that we can divide and conquer amongst, the different partners that we have. The 4th R talks about rewarding. For us, it means that we pay our women with disabilities. We pay the community health workers. This is an ongoing conversation in the health space. The fact that governments are not necessarily paying community health workers, and it is seen as a voluntary type of engagement. It is important that we are compensating women with disabilities. And the 5th and final R is represent. That women with disabilities represent their role and their identity in the community, that they have the voice and agency to stand up and articulate the issues of the entire community, that we see women with disabilities as enough, if you will. The second recommendation is around improving data collection methods. And here, through low bandwidth technology as well, we have seen in Kenya the lack of disaggregated data, which leads to a reduction in investments on issues around health and in other sectors as well. If we're not collecting this data, we really don't know where the gaps are, and we then cannot influence any change or make any investments in areas where there is need. So it is important for us, and we're recommending this to the Ministry of Health, to improve their data collection methods. We're also asking the Ministry of Health to increase the knowledge and skills of healthcare workers around disability rights and inclusion. A lot of the stigma and bias and discrimination that happens in healthcare settings comes from a cultural understanding of disability. And we need to do better in terms of upskilling our workforce to understand what disability rights are and what it means to actually provide an inclusive and accessible space and ensure that there is equity in the healthcare system. The 4th and final recommendation is recognizing the voice and agency of women and girls with disabilities, that they need to be part and parcel of engagement with policy, engagement with initiatives, and that the Ministry of Health needs to facilitate and ensure meaningful engagement with women and girls with disabilities in terms of any issue that is up for discussion within the Ministry of Health. So enhancing that engagement and sustaining ownership among women with disabilities is critical for us. This slide basically talks about, is a follow-on to the earlier slide around recommendations. The recommendations that I have just talked about all culminate or are made alive by the work that I do at Disability Trust. This is, remember I said I registered a company? Well, it was not sustainable in the long run, and I was encouraged by different donors to transition into a nonprofit so that we could deepen our impact in the community. So in 2018, we were able to transition into a trust. And as a result of this trust, we have three main programs. We have Mama Siri, we have Skills, and we have Paza. Mama Siri is Swahili for a woman who keeps a secret. Skills is skills. Paza is to amplify in Swahili. And you will see that Mama Siri, there's an arrow that connects Mama Siri to Skills and Skills to Paza and Paza to Mama Siri. So all our programs are interlinked, all our programs are interconnected. And the culmination of all the work looks to creating an environment that is disability inclusive. A disability inclusive SRHR environment is what we're looking to, what we're working towards. And SRHR plus D, this is what we refer to as our ideal vision, an environment that is disability, that includes disability when it comes to sexual reproductive rights. So what is Mama Siri? As I said, Mama Siri is Swahili for a woman who keeps a secret. And Mama Siri employs women with disabilities. You will see the link between our programs and the recommendations that we are making to the Ministry of Health, because the recommendations that we are making are as a result of all the learning that we have done over the past 12 years. So it is not, it has been action research, if you want to look at it in that sense. So it is not random recommendations. These are lessons that we have been applying internally and externally with our community. And after 12 years, we think that maybe they work. So Mama Siri employs women with disabilities, and we employ them and build their capacity, upskill them to ensure that they are able to provide community sexual reproductive health information and sexual gender-based violence response. And they do this via a toll-free platform. Mama Siri is based in 12 counties. Kenya is a devolved, we have a devolved government where we have 47 counties. Right now, we are in 12 counties. By the end of the year, we should be in 20. And hopefully, inshallah, we will be in all 47. So in those counties, we employ women with disabilities, as I said. The women are then, they are already leaders in their communities. So these are not, they're not random women. They have authenticity in their communities. And it really follows from the WILD program, principles or some aspects of the WILD program. So these are recognized leaders in the disability community in their counties. So they are required, or they have the responsibility to build networks, to build partners, database of partners that work in her particular county, and then provide referral information to anyone calling the toll-free service. To date, we have reached over 28,000 women with disabilities. And as a result of the referrals that we provide, we have also ensured 37 confirmed convictions and 46 cases currently in court based on the support from Mama Siri. Skills is our e-learning platform where we have different courses. One of the main course that we have works with healthcare providers to increase their knowledge and capacity around providing accessible, quality sexual reproductive healthcare to women with disabilities. And we have trained over 350 healthcare workers to date. PAZA, Swahili for Amplify, is our advocacy program. And PAZA builds critical mass for policy advocacy and accountability. And it works through a USSD platform where persons with disabilities can register themselves. So we collect data of persons with disabilities. We're able to conduct rapid surveys with those who are registered. We're able to communicate critical messaging around sexual reproductive rights or any other issues. And currently, we have over 40,000 persons with disabilities registered on the Hesabika platform. You will notice that all our programs run on various forms of technology. This is important because it ensures that we are able to reach more women with disabilities. And the type of technology that we utilize is also developed in partnership with the community. So it is low bandwidth technology. A lot of the time does not use the internet. So the USSD platform, Hesabika, for example, does not use the internet. Mama Siri is a toll-free, does not use the internet. And with Mama Siri, the cost of the calls are on us. So more women are able to reach us. Now, as I close, I know we talked about possibly, no, I don't think we talked about this, but yes, this is my call to action, and it is similar to what we're asking the Ministry of Health. So my call to action is to look around us in our work, in our communities, and ask ourselves some questions around, are we employing women with disabilities? Are we working with women with disabilities? Another question we can begin to ask ourselves is, are we collecting disaggregated data across our work? Are we measuring based on disability, or because this has been my experience, that because of the negativity that surrounds disability, people think it might not be acceptable to ask, or they don't know how to ask the question, are you disabled? So a lot of the time we end up leaving out disability as part of our data collection processes. The third call to action would be, are we increasing our skills and our knowledge on disability rights and inclusion? Or is our reference point our cultures? Or our own understanding, our own bias that has real implications to when we are thinking about policy or programming work. And then how are we enhancing the voice and agency of women with disabilities? It's important to know that women with disabilities can represent themselves. They just need the support and the investments like I got. Thank you for listening, and I am open for questions. And if you want to learn more about my work, you can visit our website, www.this-ability.org, and our social media pages. Thank you very much for your...
Thank you so much, Lizzie. That was amazing. There was a question in the chat about how people could reach out to you to get more information. If you want to add your email in the chat, and other links from your presentation. Thank you.
Thank you. Thank you.
Yeah, thank you. All right, so now we have a chance for people to unmute and ask our speakers if they have any questions that they want to ask anybody. Well, I do have a question for the speakers that all of you guys can answer. So Lizzie went over this a little bit at the end of her presentation, so it feeds into this well. But what is your call to action for participants of CSW NGO Forum, and as it relates to their empowerment and inclusion of women with disabilities?
This is Suze. I can offer my response, and also just thank you for everybody, all your response in the chat about just appreciating our presentations. I'm just acknowledging that. I can see that. My final thoughts on a call to action would really be to invest in disability leadership. One of the main principles of our WILD program is that women with disabilities must be leading the program, and also in the work that we support in other countries, from gender-based violence programs to creating policy and legislation. When we support women with disabilities to lead those programs, we think it really makes a difference. So not just thinking about women with disabilities as beneficiaries, including them in your programs, but finding ways to really invest in them taking the lead. And so I think that there needs to be more opportunities for, if you're looking for disability-led organizations or women with disability-led organizations, or just individual disabled women leaders, as Lizzie mentioned, and Erin, employing women with disabilities in your organization is a great way, because representation really matters too, and it creates role models for the next generation of young women and girls with disabilities to see that example of leadership. So that would be my call to action.
Great, thank you, Suze. So this is Erin speaking. So my presentation covered a lot of systems and rules. And so I think the structure is there worldwide. Of course, it's a matter of states and countries implementing it. And if you think about it, like I mentioned several times, all systems have limited resources. So, we all have to fight for those limited resources and justify the use. So part of it will be able to present how to present your organization and why, the justification of why you need the resources. And, there's many different opinions, and maybe I said some things that people disagree with, which is fine. That there's a marketplace of ideas out there. So, but I think the United Nations and its 17 subspecialty organizations are doing a great job of recognizing the disability issue as a cross-cutting issue and trying to do something about it, making that inclusion policy across the UN. So I really have been impressed. The more I researched about the situation, I'm awed at their work. So as far as the grassroots level, there's a lot of structures, a lot of language that people can use and bring to their governments if you're at the grassroots level. So those are my main thoughts.
Thank you guys. That was great, and I hope we can all take away your call to action when we leave this Zoom. In the chat, Joanne from US, she asked if any of you have been impacted by the dismantling of US aid.
I can briefly answer that. Yeah, we have been impacted by it. It's been a pretty chaotic time, I think, for a lot of us. I mean, we work in international exchange as well, so that is also being impacted with the State Department side of things. But yeah, USAID has been, devastating, and a lot of our partners who were supported by USAID funding are not getting support now. But yeah, it's a difficult time, and we're trying to stay positive and focus on the positive things and keep going forward. But we are seeing a lot of enhanced support from other sources of funders and other foundations, and those who believe that disability inclusion is important. We've been doing it for 45 years, and we're not going away. So.
Yeah, I would like to point out that MIUSA has been doing excellent work over the years, and Susan and I have been talking about it, and I have their book, Building an Inclusive Development Community, right here. It was on my shelf, and when I started talking to Susan, like, oh my gosh, I've read your book. So yeah, I'll just put it like that. And this was funded by USAID, so good stuff can happen with the support. So it's a shame that things are going away right now, but hopefully they'll come back. Lizzie, do you have any comments about USAID?
No, well, no, the changes at USAID did not affect us directly, thankfully.
Good, good.
There's no more questions in the chat, but if anyone would like to take the opportunity to unmute and ask a question, otherwise we can start to wrap up. Okay.
Yeah, I just wanted to thank our colleagues at Serve Us for
I am posting a question, sorry.
Oh, okay. Hi,
Yeah.
Rachel. And she's from Servos.
I wonder what your strategy is to address more private funding now that the governments are providing less funding.
Yeah, we are focusing our efforts just on more private foundations for funding, and we are still fundraising actually for our current WILD program, but we have noticed there's been an uptick in interest in supporting from private foundations because they understand what's going on and that is needed so much right now. So yeah, I mean, I think our strategy is that we're talking to those who are aligned with our values and understand the need. But
Great.
Didn't you submit for something on health equity for women with disabilities recently?
yes, we did. We are applying for for anything that aligns with our work aligns with what their goals are. So we are finding that there are those opportunities are still there.
It was asked, I think Lizzie, you had mentioned disaggregated data. Someone asked to know a little bit more about it, in the categories of disabilities that are visible, and likely to be impacted differently, such as like speech, vision, mental limbs, etc. And the challenges that they may face, I believe is what they were trying to ask.
Thank you for the question. Basically, disaggregated data is collecting data across, the many identities, variables, and a good resource or a widely used resource in terms of collecting disability disaggregated data would be the Washington set of questions. I can quickly look up a link. But there are very many organizations, the World Health Organization included, that also collects data on health-related factors, which could include these categories. I'll just quickly look up some links and put them in the chat. But the Washington set of questions is a widely used resource that measures the type of limitations that one might have that would then create a barrier in terms of their participation.
I just put a link to that, Lizzie, in the chat, the Washington.
Perfect, thank you.
Well, the World Health Organization has many different questionnaires. Some are very brief, like 5 items, some are 20 items, some are 100 items. So it depends on what your research question is, what's the purpose of the data. And I actually found a lot of data that can just be downloaded, like the International Labor Organization allowed me to download their data into Excel spreadsheets. So, the data's out there, and if it's not publicly accessible, you could just write and request data. But a lot of them have, big programs that are open to the public if you have certain questions, and they've had that for years. If you like for the HIV epidemic, they've always had sets of data that you can download and analyze. Any other questions?
Someone else also asked, how can we help? And my colleague Cindy Lewis put a link in the chat just for MIUSA. If you want to help WILD, you can. We do have a fundraising campaign, so there's a web page you can visit if you're interested. Yeah, but also if you are representing an organization that is interested in coming to the WILD program for the retreat that I mentioned, please be in touch by email and I can share with you how to get involved. That is another way that you could help.
Yeah, and I think with many things, awareness is the first step. So you have to be aware of the problem and like the parameters of the problem and who's involved, and then you can figure out what can you do in your place and time, right? So to define the problem, realize what resources are out there, and then go from there. But in my presentation, I tried to give you the umbrella overview. There's a lot of structure and systems set up now, but now we get to implement it. And so, I don't have the answer for that. Everybody can do their part in different ways.
And this is Suze. There was another question in the chat. Do women living with mental illness fall into the disability category? Just a quick answer from MIUSA. Yes, we include women with mental health disabilities as
Yeah. Pardon me. Go ahead.
No, go ahead, Erin. I'm sure you have more.
Oh, no, I just want to mention there's a subspecialty of rehabilitation. It's called psychiatric rehabilitation. And for decades, Boston University has been a leader in with data and research and trainings on psychiatric rehabilitation. And it's the concept of helping a person with a broad range of psychiatric issues or diagnoses return to work. And there's actually a whole slew of employment models that are very actually, a small ratio of case manager to clients because it's intensive case treatment. But there's many ways that people have found to help amplify their abilities and get them back to work and give them the support they need. And so, yeah, there's a lot of help out there.
Erin, I think someone was asking for a link to that organization. Rachel, do you have a link for that organization that you could share?
Boston University. Well, if you just put it in Google, Center on Psychiatric Rehabilitation and Boston University. I mean, I can put it in afterwards, but I'm not good with multitasking, so kind of wanted to listen here, but I could put it in the chat, but then the video will be over. But so that's how you would find the information. But yeah, there's many books and actually academic research on in the field of psychiatric rehabilitation.
Looks like Rachel says, I found it. Thank you.
Oh, thank you.
All right. And then Rachel asked, does that include head injury issues when you were talking about mental disabilities?
Oh, certainly. Yeah. Traumatic brain injury definitely falls under the disability category. And there's tons of research out there, whether it's mild, moderate, or severe traumatic brain injury, consequences of that. And in the United States, there's model systems of traumatic brain injury, so extensive network of hospitals that treat traumatic brain injury. And we know it can be related to sports, and sometimes people's personalities change as consequences of a TBI, and they may have physical effects of that TBI. So there's the medical aspect, treating it when it happens, but then there's the rehabilitation aspect, helping them get back to life as much as possible and according to their choice. I mean, not everyone wants to get back into the community or get back to work. That's okay. That's why rehabilitation meets you where you're at and tries to build up, and based on your choice, of build up the areas that you would like. So whether you want to get a high-tech job or just a quieter office job, it's all driven by the client. But yes, TBI is definitely considered a disability. As well as, there's the term invisible disabilities. There's a lot of disability, including psychiatric disorders or type 1 diabetes, or, a lot of health systems that happen internally. So an outside observer would not know that you have the disability, but you have to live with all the consequences. That's called an invisible disability. And we know there's, very different dynamics sometimes when you don't have the external indicators that you have a disability. You might have the disability tag in your car, but people see you walking around normally, something like that. Or your disability might be intermittent, wavering. So there's a lot of factors related to disability, but it doesn't mean that you don't have it. It just means that, sometimes it's manifest, sometimes it's not. But think in terms of disability as the functional limitations of a person. And that's what the World Health Organization model created, that, we always have to consider the person in their context, the social context, because if you have a better, more inclusive, accommodating environment, you'll have your disability functional limitations, but it's going to be easier for you to get around and to work, those kinds of things.
There were
Thank you.
just a couple other comments in the chat about, does OCD fall under disability? And then Rachel also said epilepsy.
Okay.
And yes, all
Definitely. So OCD is a psychological or psychiatric disorder. Yes, it would be considered a disability, but if you look at the formal systems, and yes, epilepsy, that's kind of a medically, biologically based disability. Often it can be controlled by medication. But if you talk about systems like the Social Security Administration, and I do a lot of contracting work for SSA, the disability from SSA's perspective is whether it interrupts with your ability to perform work. So people who have disabilities, and they may be very severe, but if they're working, they cannot get benefits because they found a way to figure it out. And it doesn't mean that your disability doesn't exist. It means that, you're earning enough, and Social Security disability benefits that's a work disability program in the United States. So if you can go out there and get a job and find the right job for you to work around your limitations, but also, fit your skills and abilities, and which means it's a sustainable job, then you won't have a work disability, but your actual disability still will exist. Because typically it doesn't go away. Well, sometimes it does with treatment, but it's also about managing your health condition, like epilepsy, type 1 diabetes. It's all about self-management of your condition. Did I answer the question? Questions?
Yes, thank you. It doesn't look like any more questions have been posed in the chat.
Well, this is Suze. I want to thank Sophia and Paige for organizing this session, everyone for coming, and also our ASL interpreters have been great too. Thank you.
Yay, thank you.
My co-panelists, thank you so much.
Thank you. Excellent work. I appreciate it.
Yeah, thank you so much to our interpreters and for all of our speakers. And thank you, Servos, for helping make this event possible. And thank you, everybody, for coming.
All right. Thank you, Sophia. Bye. Thank you.